Good afternoon and welcome to today's webinar, Measuring Benchmarks, Indicators, and Tools. I'm Lauren Suplee. I'm the Federal Project Officer on the contract of supporting these TA presentations. This webinar is one of the TA resources available as part of the Maternal, Infant, and Early Childhood Home Visiting Program. Today's presentation will feature three speakers. First is Dr. Carlos Cano. He's a medical officer with the Health Resources and Services Administration. Prior to returning to the Department of Health and Human Services, Dr. Cano was responsible for programs in maternal and child health, school-based health services, primary care, and performance evaluation in the District of Columbia as Senior Deputy Director of the Department of Health. Trained as a psychiatrist and family therapist, he has experience synthesizing and evaluating the evidence on clinical risk and benefits for diagnostic and therapeutic interventions at the Centers for Medicare and Medicaid Services. Dr. Cano has a medical degree from the University of Buenos Aires, Argentina, and a master's degree in public management from the University of Maryland. Our second speaker is Susan Zayed. She has 12 years experience in program evaluation, applied social science research, and evaluation technical assistance. She has worked as a lead evaluator on several projects independently and as part of a research team on a multi-site statewide project. Ms. Zayed is proficient in survey design, database design, creating and training data management systems and protocols, and creating and training in data collection interview tools and protocols. She also has experience designing implementation plans and monitoring adherence to implementation plans for several home visiting programs. Ms. Zayed has extensive experience in working with federal home visiting programs and is familiar with Texas and federal child welfare legislation and policy issues. She also has experience in providing site-specific technical assistance to grantees, as well as in creating site visit data collection protocols and conducting site visit interviews as part of a state contract to evaluate and provide technical assistance to state grantees. Our third presentation is Dr. Mary Clute. She has directed several multi-site research and evaluation studies, including evaluations of the Institute's 2 Early Reading First grants and the Denver Preschool Program Evaluation Project, and a validation study of a school readiness assessment called the eStart. She's an active member of the Early Head Start Research Consortium and the Balanced Learning Network. Dr. Clute's fields of interest and expertise include the examination of preventative interventions to support children's social and emotional development and school readiness, with a focus on children living in poverty, methodology, and statistics. Much of her current work focuses on how early childhood education programs can use data for quality improvement. Mary received her PhD in Human Development and Family Studies in 1998 from the Pennsylvania State University. Today's webinar is one as part of the DOHVE project, or Design Options for Maternal, Infant, and Early Childhood Home Visiting Evaluation. The purpose of this project is threefold. One is to design options for the federal evaluation of evidence-based home visiting programs. 2 is evaluation-related technical assistance for the promising approaches. And 3 is technical assistance for grantees' continuous quality improvement, management information systems, and benchmarks. The DOHVE team includes a stellar group, including James Bell Associates, MDRC, Cincinnati Children's Hospital Medical Center, and Every Child Succeeds, as well as a number of outstanding consultants. The goals of today's session are to provide an overview of the legislative requirements for measuring and reporting benchmarks, to cover the issues to consider when identifying data sources and instruments to assess participant outcomes, and 3, using data to guide services and quality improvement efforts with a grantee example from the Clayton Early Learning Institute. I will now turn the session over to Dr. Cano.
Thank you, Lauren. In my segment of the presentation, I will address the requirements for benchmarking and reporting. I will also highlight the opportunity the home visiting program represents. Some say is unprecedented, at least for many years. Opportunities to advance the field of early childhood and development as a whole. Start the talk with the legislative language and focus on a few key terms. Judged or measured. a home visiting program, a benchmark can be simply a starting point. That is, an indicator or measurement at baseline against which we can compare measurements at a later time and determine if we have made progress or not. For example, we could compare the percent of participants in a home visiting program who received a referral and completed it during year 1 with the percent of participants with completed referrals in year 2 and see if the percent has increased. In other words, measuring an important characteristic of the program or the participants at the beginning provides the basis for a before and after assessment. The key point to note here is that we're not required to use external benchmarks or comparison groups. The participants are their own comparison group. As the legislative language indicates, the families participating in the program constitute the universal observation for all the measures. Finally, we have the concept of a benchmark area. This is the domain in which we need to demonstrate improvement. School readiness, maternal and newborn health status, referrals and coordination with other community resources, they're all benchmark areas defined in the law. Home visiting grantees are likely by now familiar with the benchmark areas listed in the legislation. Also, Section 5 of the Supplemental Information Request, or SIR, published a few days ago, provide guidance on the data collection requirements for the 6 benchmark areas on this slide. Each benchmark area includes components or constructs, which is a term that appears in the guidance. The constructs support or contribute to the achievement of the desired outcome in a given benchmark area. For example, under the area of maternal and newborn health, we know that almost half of the mothers typically served by home visiting programs experience moderate or severe depressive symptoms. The presence or absence of depression is then a significant contributor to the health status of these mothers. It is a construct to be measured in that specific benchmark area. Another example is regulation of emotion among children participating in the program, which is central to a child's ability to learn. This is another example of a construct under another benchmark area, school readiness and achievement. Appendix D of the SIR includes a complete list of the 30-plus constructs for all the benchmark areas. The number of constructs under each benchmark area varies from 2 to 9. By way of a concrete example, let's drill down into the first area, improve maternal and newborn health. It includes a variety of constructs such as prenatal care, parental use of alcohol, tobacco, or other drugs, breastfeeding, and well-child visits, among others. There is more than one measure or indicator associated with individual constructs. Let's take as an example screening for maternal depressive symptoms. We can choose a process measure centered on program activities, such as, for example, the percent of women participating in the program who are screened for depression in a given period. We would want this number to go up over time until all expectant women and mothers participating in the program are screened routinely. We can also select an outcome measure, such as, for example, the percent of women in the program who screen positive on a depression scale. And we will want this number to go down over time. Note that some benchmark areas overlap. For example, the health of a child is a factor in school readiness and in visits to the emergency department. If grantees adopt a measure that captures a construct relevant to more than one area, that one measure can be utilized in both benchmark areas. So any observed improvement in the construct would count under each area, essentially twice. So the guidance requires that grantees report on all constructs for all benchmark areas. This is a reporting requirement. The information should be based on data from participants in the program, that is, on individual level data. Data on individual participants are the building blocks for program-wide indicators. Individual level data that need to be then aggregated to create the indicators that will show program-wide improvement. Achieving change in communities at risk is a goal we probably all share. However, since the size of any given home visiting program may be relatively small, and improvement at the community level is dependent on other available resources, showing improvement at community level indicators is not expected of home visiting programs on their own. Indicators at the community level, therefore, need not be reported. HRSA and ACS, with respect to the last bullet point, the templates for annual reporting, will release these templates at a later date, so this should not be a major concern in preparing the updated state plans. A word on flexibility. States may be currently collecting data for children and families on constructs that are quite similar or even identical to the ones listed in the guidance. The intent of the national program was to avoid an outcome where a grantee would be required to measure and report on the same construct in multiple ways. Grantees have the flexibility to select the indicator for each construct that best suits the needs and circumstances of the programs. States can also choose the instrument or tools to perform the measurement. To continue with our example on screening for depressive symptoms, programs can utilize any tool considered valid and reliable to perform the individual screenings. The DEC inventory and the Edinburgh postnatal scale are just two instances of such a tool. And we're in the process of developing a compendium of measuring tools to make available to grantees on a wide range of constructs. Finally, states can also define and quantify what will constitute improvements. So, what is improvement? The federal government, the state, and the public expect that the home visiting programs will make a difference for the better. We all want that difference to be real, that is, to benefit the participants in the communities that will be served. The legislation builds accountability mechanisms, including the use of the benchmarks and constructs that we're discussing today, to show this change. But we all know that compliance requirements can be burdensome at times. In this regard, HRSA and ACS would like to see grantees and implementing agencies succeed, and for the changes we all seek to be attainable. Grantees are probably at different stages in setting up their home visiting programs, and that is why the federal government is deferring to grantees in defining improvement, so that it is achievable for all. That is also a reason grantees are expected to show improvement in some, but not all, the constructs by the third year of the program. And as mentioned earlier, improvement can be based on process measures, for example, increasing the percent of children participating in a program that are screened for developmental delays in a given year. And it can be shown with outcome indicators. Improvement can be a reduction in the percent of participating children within an age group that is at risk for developmental delays. At this point, it would be helpful to mark the distinction between benchmarking as a way of measuring performance and evaluation. Evaluations generally require a separate comparison or control group, which is a prerequisite to set up either experimental or quasi-experimental design. Performance monitoring typically utilizes a before and after design. Program participants are their own control or comparison group. The basis of comparison is given by the pre-intervention measures taken from participants themselves. This is how home visiting grantees are expected to measure improvement. Benchmarking under this program should be understood as performance monitoring, which most social service programs utilize in one fashion or another anyway, rather than evaluation. Finally, it is often said that if you can measure something, you can improve it. Our hope is that grantees go from being users of these indicators and measures to being their owners. We seek to encourage measurement that is meaningful for grantees' purposes. We hope to move beyond a context of compliance driven by the grantor to one of continuous quality improvement driven by the grantees. That is the reason behind the decision to defer two grantees on the measures they find useful for their own purposes and to encourage continuous quality improvement as a central programmatic goal. So in summary, this is the accountability framework for the program with regards to benchmarks and measures. This slide displays the required components of a benchmarking plan to be submitted by grantees. The items are included in the second half of Section 5 of the guidance. The updated state plan must propose valid measures, define improvement, and also propose thoughtful data collection and analysis activities. Ultimately, the purpose of these requirements is to increase the confidence that the measures are valid, that the improvement is real and sustained, and that the data are properly safeguarded. Susan and Mary will address some of the technical aspects of these requirements in more detail in a few moments. I would like to end my segment of the webinar by highlighting the opportunity the home visiting program represents. Although accountability is clearly important and mandated by the legislation, we would hope grantees will regard this initiative as an opportunity to integrate their early childhood programs and engage in policy experimentation in partnership with the national program. Benchmarking and data coordination to guide decision-making and to target services across programs could be a very robust driver of this transformation. And we all know that individual evidence-based programs and models are essential in this effort. But if in 5 years all we achieve is having put in place a larger set of standalone evidence-based home visiting models, even if successfully implemented, we will have missed an opportunity to have a greater impact on the populations we serve. There is a lot of promise in expanding the unit of analysis from models to the larger system supporting early childhood health and development, a system of systems. One sort of service integration can occur among home visiting programs. Right now, states are experimenting with different approaches that bridge program models by developing common processes or a common outcomes framework. For example, programs are utilizing centralized intake, shared assessment tools, and also common indicators across home visiting programs. Home visiting has its own portfolio of interventions for improvement, but it is also a gateway to other services. Integration can occur across sectors, including health, childcare, education, and family support. And home visiting can be utilized as a lever to connect these various sectors. In a recent conference on home visiting, somebody put it as a platform for apps, so to speak. And experimenting with different governance strategies can also lead to integrating home visiting into a comprehensive early childhood system. States have been developing governance bodies that encompass a range of traditionally separate EC programs, early childhood programs. This is sort of a top-down approach as opposed to bottom-up, driven by the home visiting programs themselves. Governance strategies may vary by state. For example, an ACS grant-supported Early Childhood Advisory Council, or ECAC, may have purview over various agencies serving young children and the ability to advise the governor to develop a common policy agenda or a common outcome framework. Other states may utilize the Early Childhood Comprehensive System, also known as ECCS, which is a grant from HRSA. And in these instances, a state may encourage administrative consolidation of various programs serving vulnerable children under a single agency. So there are many ways in which the governance strategy can vary. And integration can also occur across time. Some states are using unique identifiers and moving from the collection of snapshots of the status of children to the analysis of longitudinal data, including K-12 data linked to early childhood. Integration can occur also within a small geographic area. Private foundations, in partnership with state governments, are funding a variety of place-based initiatives to bring people together, to connect programs, and to target services in neighborhoods and other communities. So let me finish by suggesting that institutional experimentation at the local, state, and multi-state level could bring about transformative change at the national level, perhaps by the end of the 5-year period or a program. Viable and successful local experiences could be scaled up and adopted regionally or even nationally. There is another reason why we hope to cultivate this partnership between federal and state governments, including ongoing consultation during the development and the review of the updated state plans. As I mentioned earlier, it is likely that grantees are at different stages in their effort to develop a home visiting program. We hope to meet each grantee where they are at and provide technical assistance as needed. We would also like to stimulate collaboration among states who may be facing similar challenges and potentially benefiting from similar solutions through the facilitation of peer learning networks. And with this, I will pass it on to Susan.
Thank you, Carlos. So as Carlos mentioned earlier, the recently released SIR requires all states to include a plan for collecting benchmark data in their updated state plans. Let me go to the next slide. The plan must also include information about the measures selected to assess each construct across the 6 benchmark areas. The measures selected must include a description of each measure, the reliability and validity associated with the measures, and an analysis plan. Constructs must be defined in a way so that they are measurable and quantifiable, and they must be assessed at different points in time to measure change. We'll probably need to use multiple data collection methods to assess all the constructs. Data sources can include self-report interviews and surveys, direct observations, or administrative records. Here are just a few of the things to consider before deciding on a data collection method. For example, if you rely on data collected through interviews, you'd want to be sure to adequately train interviewers to avoid potential biases, such as deviations from the interview protocol. On the other hand, interviews may provide higher item-by-item response rates. If using self-report surveys, keep in mind there is variability in cost across assessments. Also, it would be helpful to have a plan to address response rates. Data collected through direct observation requires thorough training of staff to ensure the accuracy and consistency of the data collected. Finally, administrative data can be very time-consuming to collect, but it can provide very valuable data. It also takes the burden of data collection off frontline staff. So when selecting a data source to measure a construct, ask yourself these questions. How accurate will the data be? How costly will it be? What are the steps required to access the data? How often will the data be collected? And what is the level of effort? So to determine the best data source, you must decide what data source would best capture how you define the construct. You should also take your population needs and characteristics and other contextual factors into consideration when selecting a data source. For example, when measuring emergency room visits, is it better to use self-report data or administrative medical records? There are pros and cons to each. For instance, if you want to use medical records data and there are multiple hospitals in your geographic area, what are the steps you need to take now to gain access to the data on your families from each hospital within a given area? If you're using self-report data, the data may be less reliable than medical records data. So what are some steps you can take to improve the accuracy of your data collection? So now let's talk about defining your constructs. Before you can decide on how to measure your construct, you must clearly and precisely define your construct. You must have a well-defined construct before you decide on a measurement tool to assess that construct. HealthyPeople.gov is a great reference for how to define constructs and write objectives or definitions of improvement in ways that are quantifiable and measurable. Take the example on this slide. The objective for the prenatal construct reads, the program will increase the rate of pregnant women served by the program who receive prenatal care in the first trimester by 10% from year 1 to the 3-year benchmark reporting period. So you can see the objective is written so that it is quantifiable. You want to increase the rate by 10%. It's specific. It's targeting prenatal care in the first trimester, and it has a well-defined time frame. It will measure pregnant women in the program at baseline and again at year 3 to look for changes in the rate. Once you've defined your construct in a quantifiable and measurable way, you can decide what data source would be the best fit for your program. Now we're going to discuss some factors to consider when selecting measures. Is the measure standardized? What are the training requirements? Is it reliable? Is it valid? Is it sensitive to assessing change and specific to what you're measuring? What are the costs involved? Can the data be used by staff for continuous quality improvement? And what is the level of appropriateness for your target population? We'll discuss these factors in a little more detail in the next few slides. So let's start with the first question when looking at a possible measure. Is the measure standardized? First, what is a standardized measure? A standardized measure is designed in such a way that the questions, conditions for administering, and scoring procedures and interpretations are consistent. Simply, it means the same test is given in the same manner to all subjects all the time. It also means there's an established protocol for scoring and interpretation of the results. Standardized measures are generally preferred over non-standardized measures because they're easy to administer on a wide scale, and the scoring and interpretation procedures are readily available. They're often inadequate for describing subgroups. They may also be culturally biased or less appropriate for a specific population. If you're using a standardized test, it's important to consider the norms group your population will be compared to, and if the findings are generalizable to the population in your program. Another caution when using standardized measures, just because an assessment is standardized, if administered inappropriately or scored inappropriately, or the results are interpreted inappropriately, the results can be meaningless. One example is administering a timed test under untimed conditions. Another example, if staff are not trained appropriately, the assessments may be administered inconsistently to participants. Another important factor we touched on is training. Whether you're using measurement tools with highly specific training requirements or one without specified training requirements, training is still necessary and relevant before administering a measure. A detailed protocol should be established regarding how to administer an assessment and how to handle the data once it's collected. Additionally, it's helpful to have periodic booster trainings to refresh staff on the data collection protocol. So even if a staff member was trained 5 years ago, she's still administering the assessment using the same protocol as she did in her first year. Another factor to be considered when selecting measurement tools is the reliability of the measure. Reliability estimates the consistency of your measurement, and more simply, the degree to which an instrument measures the same way each time it's used under the same conditions with the same subject. For example, if you're using a developmental screening tool and you administer it to the same participants within 24 hours, you should get the same results tomorrow as you did today, since you don't expect child development to change significantly in 24 hours. Validity, on the other hand, involves the degree to which you're measuring what you're supposed to, more simply, the accuracy of your measurement. For example, if you define a construct so that you want to improve children's social and emotional development, but you're using a measure that focuses strictly on physical development, the results may be reliable, but they are not valid because the tool is not measuring what it was intended to measure. So what's the difference between reliability and validity? Here's a graphic representation of the relationship between reliability and validity. In the first illustration, you've got an example of a shooter that's reliable. The shooter is consistently hitting the same area of the target, but she's missing the bullseye. To be a valid measure, you've got to hit the mark, so to speak, or measure what it is you're trying to measure. If an instrument does not accurately measure what it's supposed to, there's no reason to use it, even if it measures consistently. In the fourth figure, this represents a measure that is both reliable and valid. Not only does it accurately measure what you want, but the results are repeatable. The arrows are consistently hitting the bullseye. Now let's talk about sensitivity and specificity. A sensitive measure has the ability to detect differences between groups. For example, if you're testing for developmental delays, a highly sensitive assessment will correctly identify at a high rate developmental delays among participants. A highly sensitive measure is not likely to let a child with a developmental delay fall through the cracks. On the other hand, highly sensitive measures often have a tendency to inaccurately label those without a developmental delay as having one. Specificity refers to the ability of an instrument to correctly screen out those individuals who do not have a specific condition. A highly specific measure will be able to accurately screen out those children without a developmental delay. On the other hand, highly specific measures often have a tendency to inaccurately screen out those children who may actually have a developmental delay. Another important consideration when deciding on a measurement tool is to consider the costs associated with the measure. What are the financial costs to using a measure? How much does it cost to purchase the assessment, to train the staff, and possibly to hire the appropriate staff to collect the data? There are also costs associated with time. How much time will staff spend implementing and using a measurement tool? Can this tool replace another tool? And can this tool be used for the program's continuous quality improvement, thereby adding a benefit that could justify the added cost? So ideally, collecting data on benchmarks should be integrated in the program's DTI efforts. Not only do you want to collect the data because it's required, but you want to be able to use the results ongoing to improve the quality and effectiveness of your program. The previous two DOHVE webinars dealt with continuous quality improvement reward reps, and they're available on the DOHVE website if you've missed them. The final consideration when selecting measures is to consider the appropriateness of the measurement tool for your target population. Is the measure culturally appropriate for the population you're working with? Is it age or developmentally appropriate? Are there any language barriers or literacy barriers that may make this measure difficult to administer to the population you're working with? These are important questions to ask before implementing a measurement tool. Of all the considerations we've discussed on the previous slide, determining the appropriateness of the measure for use with your target population could arguably be the most important factor to consider. You can do everything else right. You can select a standardized measure that is reliable and valid, train the staff, and follow the data collection protocol to a T. But if the measure is not culturally appropriate, or if it is at a higher literacy level than most of your participants, then all those other factors are meaningless. So in the presentation, we've touched on some important factors to consider when selecting measures for constructs across the 6 benchmark areas. While this presentation provides a brief overview, the DOHVE team is creating an accompanying document to this webinar that will elaborate on the content of this presentation. This document can serve as a resource tool to help grantees select appropriate measurement tools to assess benchmarks. When released, it will be made available for download on the DOHVE website. Now I want to take this opportunity to let you know about another resource tool that is currently under development that can hopefully help you select possible measurement tools for your construct. The DOHVE team has compiled a compendium of measurement resources relevant to home visiting. This was done by scanning the literature for existing compendia and resource tools. After compiling measures across compendia, eliminating duplicates, and excluding those that lack sufficient information, approximately 150 measures were included in this resource compendium document. The measures included in the compendium are listed by outcome domains commonly used in home visiting programs. Each measure included in the resource tool provides a brief description of the measure, scale and subscale information, as well as a link to locate the measure. Given the vast array of measures, this document is not intended to be exhaustive or to cover the span of possible measures across domains. Rather, it should be viewed as a resource to provide possible measurement tools commonly used to assess outcomes typical to home visiting programs and to supplement existing information in the field. The DOHVE team will also periodically update the compendium of measurement resources. The compendium, when released, will be available for download at the DOHVE website at the web address on this slide. I'm now going to pass the presentation on to Mary Clute from Clayton Early Learning Institute, who will give you a real-world perspective on how their site was able to implement data collection and how they're able to use data ongoing for continuous quality improvement.
Thank you. So I was asked to join the webinar today to talk a little bit about my experiences with implementing a project where we collect quite a bit of data. And the project is an evaluation study in a birth to 5 early childhood education program. And prior to embarking on this study, I had years of experience as an external evaluator for programs. And for those projects, we'd often start with a design, we'd write about the program, we'd collect data, we'd write a report, and we'd send it off. And sometimes we'd feel like the report had an impact, but most of the time it felt like just something that we did to meet a funder's requirements. And then I became involved in this project that I'm going to talk about today, and it was a very different experience because a major goal of this project is to really build a research program partnership. And I wouldn't say that we've completely achieved our vision yet, but in the past 3.5 years we've made a tremendous amount of progress and we've learned quite a bit. And even though the context for my project is a little bit different than yours, hopefully some of our learnings will be useful to you as you embark on your benchmarking endeavor. So first I'd like to give you a little background on the program and on the research project. So the program that I work closely with is an Educare school. And currently there are 12 Educare schools in a growing network called the Balanced Learning Network. And the seed funding for this work comes from a partnership from the Ounce Prevention Fund and the Buffett Early Childhood Fund. So when you put Buffett and Ounce together, you get Bounce. That's the origin of the name. Educare centers provide high-quality center-based care to low-income, high-risk families using blended public and private funding. And they're guided by 12 core features. But most relevant to the conversation today is the core feature that has to do with using research-based strategies. And this means drawing upon existing research about what works best for children and families, but it also means collecting and using data to drive decision-making in the program. And this is where the Balanced Learning Network implementation study and the research program partnership come in. So every Educare school has a local evaluator like me who implements a comprehensive evaluation study called the Balanced Learning Network implementation study. And this study involves a great deal of data collection. At our site, we conduct direct standardized assessments of all the children served by the program, about 350 children, twice per year. And we use different assessments for different age groups, but we use 7 different assessments in total. And then in addition to the twice-yearly assessments, we also do standardized assessments of children when they turn 2 and when they turn 3. We also do annual parent interviews, and we observe classrooms annually using the ITERS-R, the ECRS-R, the ELCO, and the CLASS. And then we also do annual staff surveys and exit interviews with parents of kindergarten-bound children. So it's quite a bit of data collection. And our motivation for collecting all these data is to begin to tell the story of the impact that Educare has on the families it serves. But we won't stop there. Our project is guided by a commitment to make this more than an evaluation that ends up in a report that sits around collecting dust somewhere. We try to make the data we collect useful to the program through a continual process of sharing data with the program in ways that can inform decision-making at all levels, from the teachers in the classrooms all the way up to the program leadership. And program staff also provide input into what types of data we collect and the procedures that we use to collect data. We've had lots of false starts and bumps in the road as we've tried to build this research program partnership, but I'd like to share some of the strategies that have helped us to be successful. Like I said before, this project is different from what you're embarking on because it's a center-based program. And this project probably has more of that program evaluation sort of bend to it than your work. But our hope is that some of these lessons will apply to you as you embark on collecting data on these benchmarks in your home visiting program. So our first thing that we really worked on is minimizing burden. This program that I work with existed before it became an Educare school, and during its long history, they participated in a lot of research studies. And often these projects were perceived by the staff as a lot of burden and inconvenience because they were really impacted by the data collection, and then they'd never really hear much about the results. Or if they did, the information they got often wasn't very useful. So we thought we'd just by making really public and intentional efforts to minimize burden on the staff. And we did this by incorporating study procedures into the existing structures as much as we could. So one example of this is that we needed to get informed consent from all the families to participate in the research study. And at first, we did this separately. We asked people to, do the informed consent process with each of the families. And then one of the staff members mentioned that, there's a time when they do paperwork with families, and that's when they enroll them in the study. And so we made some tweaks to our procedures so that they could do the informed consent process while they were doing enrollment. It was a really small change, but it had a huge impact. And now it's very easy for us to get consent on all the families in the study, and all the families in the program, excuse me. Another example is that we tried to look at what the program was already collecting and how we could use that to meet the needs of what we wanted to find out about in the study. So we needed a measure of socio-emotional development, and we found that the program was already using the DECA, and the DECA has good psychometric properties, so we were able to use that for the study. So now that same measure that they were already doing is being used to meet Head Start performance standards, but it's also being used for our study as well. But minimizing burden only goes so far, and even if it's a small burden, it's still a burden. And so the program management was already on board with this today. They were interested in seeing the results, and they were totally on board with this. But often with program evaluations or efforts to collect benchmark data, the people most affected by the data collection may not be as invested in the study. And so I think one of the best things that we've done is to share results with program staff frequently. And so after each data collection round, we provide classroom-level reports that show the assessment scores over time for every child in each classroom with teachers. And we meet with the teaching team to go over these reports, and we talk about what sort of trends we're seeing over time for individual children and across the classroom. And we also provide letters explaining the assessment with each child's score so they can give that to parents. At first, when we started doing this, we tried to feedback data to teachers by just handing them a pile of letters when we were done with data collection. And the feedback that we got from teachers was that they didn't feel equipped to explain the letters to the parents. And so that's when we started having these meetings to go over it, and then they became experts in interpreting the data. Once they started understanding the assessments and the meaning of the scores, we got feedback from them that they would love to have these data for parent-teacher conferences. And so what we did was we sort of tweaked our data collection windows a little bit so that we could have everything done for parent-teacher conferences so that they could use this data that we were collecting to help them meet a need that they already had, which was sharing information with parents regularly. And this has become so ingrained in the program now that actually I just got an email a couple of weeks ago from somebody who was working on the program calendar, and she wanted to run the dates for parent-teacher conferences by me to make sure that they would work for our data collection schedule. So it's a great example of how this has really become a part of the work of the day in the program, which is really exciting. We've also seen other examples of staff that have moved away from being really resistant about the assessments to places where they're eagerly awaiting seeing information. There's teachers who used to sort of be very upset with us for coming and pulling children out of their classrooms to do assessments, and now some of those same teachers are asking us for the information about children's assessments because they have a question about the child and they think that that extra piece of information might help them understand what's going on for the child. Another thing that we learned to do was to negotiate a data sharing schedule, and we put it in writing. And so we sat down and we talked about what kind of information we had, when, and when we could share the information. And so we put it in writing, but we're also open to revising it continually. And over the years, it's changed quite a bit. When we started out, it was something very simple. We shared individual scores with teachers, like I just mentioned, twice per year. And then we provide aggregate data to the program once a year. But over time, this has grown because people have wanted more information over time. And so now what we do is at the close of every data collection window, I present aggregate data to the program leadership. And usually when we have these discussions, they prompt a lot of questions that we hadn't thought of before. And that usually leads to me going back and doing more analyses and coming back the next month with another presentation. And over time, the questions and hypotheses that the program have generated have gotten more and more elaborate and sophisticated, which is really exciting because they're sharing the data with them is improving the questions that I ask of the data, and it's generating more, deeper, interesting information, which is really exciting. I also prepare a written annual evaluation report, which gets discussed by program leadership, and that also gets presented to the Head Start Policy Council, and then it also gets presented to our Board of Directors. And this year, something we're working on is trying to make the annual evaluation report inform program planning in a more intentional way, and using it to set goals for the coming school year. We're also trying this year to involve more frontline staff in that process, so teachers and we have staff called child family educators that work directly with families. And we're trying to get them involved in the process this year, the school setting process. And so basically what happens is it keeps on evolving. How we share data and who's involved and who data gets shared with is evolving over time. But we always try to actually be very intentional about it by writing down what we're doing and revising the data sharing schedule and circulating that. Because that way it really cuts down on last minute requests that are hard to accommodate. And I think it helps with create sort of an environment where everybody knows what kind of information they might get when. Another thing that we've done is try to really make use of all different kinds of information and value all kinds of information. So when we started this process, we found that there were some pockets of people who felt like the research study was somehow more real because we had numbers and statistics and that sort of thing. And some folks were really threatened by this, and that really hampered our developing partnerships. And we sort of broke down some of those barriers by when we discuss individual children's scores with teachers and when we look at aggregate level program data, we always try to ask the question of how what we find from the research study fits with what they're seeing in their work. And they have some sort of more formal types of data collection that they do as part of the program. Like, for example, teachers do authentic assessments with children. They also do some screeners with children. But they also have their impressions and their expertise. And sometimes everything lines up really nicely and leads to the same conclusion. So what I find in the research study, what we're finding with the data, lines up with the data that they collect, and it lines up with their impressions, and everything triangulates beautifully. But sometimes it doesn't. And when it doesn't, we try to avoid the conversations about which is right and which is wrong. In the beginning, there were a lot of folks that the conversation sort of went there quickly to the, well, that doesn't agree with what you're presenting doesn't agree with what I see, so what you're doing must be wrong. And it's just that kind of leads to like a sort of defensive sort of pattern. And so we really tried to break that down and really focus on that's not the important question about which is right and which is wrong. It's more about what do these different kinds of information tell us, and what sort of things do we need to gather more information on to really understand why they don't line up. I would say that we've been better at achieving this goal of sort of triangulating data in this way in our discussions of individual children than we have in our discussions of the aggregate data. But this year we've been really embarking on a very intentional effort to try to look at data from the evaluation side by side with program data to try to see if they do line up. But we've run into some sort of logistical bumps in the road with that we're working on overcoming, and I think that once we do, it'll be even richer discussion. And then finally, one of the things that we've been really having to always remind ourselves to do is to focus on this as a journey instead of an endpoint. A lot of us who are engaged in this work really have this vision for this dynamic research program partnership that we have a vision of what the endpoint can be, and we can get really discouraged when we see how far we are away from it because we really haven't achieved our vision yet. But when we're really feeling low and feeling like there's no way we're ever going to achieve that vision, we find that it helps to really reflect on where we started. And we've come a tremendously long way from where we started, and that is very motivating and very encouraging. So that's the end of what I have to say. I'm turning it over to Sharon, is that right, or Joe?
Jill, yes. Well, thank you, Carlos, Susan, and Mary. This information will be helpful as states, tribes, and territories move forward with developing their plans for measuring the benchmarks as specified in the supplemental information request guidance. As Lauren mentioned in the beginning of the webinar, this webinar is just one source of support we are providing to the federal home visiting grantees. We have conducted 2 webinars before this one on building a culture of quality in home visiting, which was on January 13th, and another on designing and using effective data management systems. All of the webinar slides and recorded sessions are available at the website that you can see below. Next steps. Please stay tuned for additional webinars, individualized TA, and other information from the DOHVE Evaluation Technical Assistance Team. As mentioned previously, we are working on a compendium of measures. We hope this will be available to grantees in the next 1 or 2 weeks. To accompany that, we are working on a written brief about selecting measurement tools, which, as Susan mentioned, will provide some more specific details about the factors to consider when selecting measurement instruments. We are also developing a measurement tool for tracking information on referrals and coordination, which will be available to grantees within the next month or so. And we also have another webinar that is scheduled for April 14th. That's another Thursday at 3 p.m. Eastern, which will focus on conducting rigorous evaluations with small sample sizes. So now we're going to turn to the questions that we have received through the question and answer panel. As a reminder, if you would like to submit a question, you can do so on the bottom right-hand corner of the screen. We have received a lot of questions, so if we don't get to your question today, we'll respond to you offline. We are developing an FAQ, which will be posted on the website that was mentioned previously, and I'll put that slide back on in a minute. So the first question is from Mary. Mary, did you do any work with staff before data collection to get them on board?
No, and we probably should have. So, like I said, the program had been involved in a lot of, we had had an early reading first grant prior to becoming an educare center, so there was groups of people who were used to having their kids pulled out for assessments, but we didn't. We sort of, I think it comes from my background as being sort of an outside researcher who just comes in and collects data, and less of a partnership kind of situation. And so I really started out, and I made some big mistakes by approaching it that way in the beginning. But the thing that really got staff on board was by sharing the information back. And that's really where they interact the most with it. They don't have to collect the data. We have staff to collect the data for them, but they it is disruptive to their classroom when we come and pull kids out.
Okay, great. Susan, Carlos, or Lauren, do you have anything to add?
No.
I think that was well said.
Okay. Okay, the next question is, how can we explain the scores we get? For example, what if one site has really high-risk participants, which makes it difficult to show improvement?
So this is Lauren. I'm happy to start, and then other people can add. I think one thing that the Supplemental Information Request, or the SIR, as we all refer to it, talks about is collecting information about the participants in the program, information about demographics, information about dosage, and the amount, other variables like that. And I think those variables can be really useful in contextualizing the data that you receive, and when you're reporting on it, would be important to explain what's going on in that program or in that site that may help you understand some of the data.
Okay, next question. What kinds of technical assistance will be provided on measures that are within a specific domain?
This is Lauren. I'll take that one too. I think our hope is to provide some more specific technical assistance by offering forums such as targeted conference calls on each of the domains within the benchmark to really dig deep into some of the very specific questions that I'm sure many of you have, either now have or will have as you start to have your meetings about how you're going to approach the benchmark's requirements. And we'll let you know when those are scheduled.
Okay, thank you. The next question is, do we need to collect data on all benchmark domains, or can we use data like Medicaid records for some of the data?
Carlos, I'm happy to take this one unless you want to.
Oh, sure. Please go ahead.
So I think we stated in the SIR that we encourage programs to use administrative data to the extent that's feasible and practical. It does have to be individual level data, so you would need access to that level of data. We recognize administrative data can relieve burden on the home visitors or others that are collecting the data. But we also recognize that either sometimes it's difficult to get it at the individual level, or we also caution you to be very careful that the administrative data that you're accessing really captures the construct that is specified in the SIR. So you should, when you're asking questions about getting access to the data, make sure you truly understand what that variable will get you.
Okay.
Okay. The next question is, can we use the data that we are already collecting for our home visiting model?
Yes, and we encourage you to do that. We also, this is what Carlos mentioned about flexibility, in that we hope that we are not increasing burden, but will allow you to use the measures that some of your home visiting models already require you to use for this purpose.
Just to add to that, there may be some constructs that are very well captured by measures or performance measures that you may be utilizing for other programs within your agency. And examples that come to mind are the maternal and child health block grants or other discretionary grants under the Maternal and Child Health Bureau.
Okay. The next question has to do with the evidence-based program list that Carlos mentioned. So the question is that there is this list of evidence-based programs, and you mentioned that there's a lack of evidence to support construct improvements in all benchmark areas. Can you expand on that?
So, this is Lauren, and I'm actually also the Federal Project Officer on the evidence review, and I think this is what the question is getting at. The legislation does require that all states report on all benchmark areas and demonstrate improvement in 4 by year 3. And the Home V review is a review of the evidence that's currently available from previously conducted research. So this can be used to gauge the outcomes that programs have achieved, but if a home visiting program has added enhancement or other supports and some of the models have adapted over time, then additional outcomes may be obtained. And I think states need to really think carefully about the previously achieved outcomes and the possible necessary supports for their home visiting program in order to comply with the reporting requirements put in the legislation.
Okay, great. And I went back to the slide that lists the website that the archive slides and the audio records are. Okay, so the next question is, if the choice is made to expand currently existing programs with this funding, is the expectation that data will be collected and reported only for families that are available or that are able to be served with this funding, or on all families served?
Carlos, do you want me to take that, or do you want to take it?
Sure.
So, the requirements in the SIR are to only collect this data on those families being funded through the new federal program. However, since we are encouraging states to think about this data as part of your continuous quality improvement, we encourage you to collect the data on participants in the program to get a context about what's going on in the program and to use it for programmatic decision-making purposes. But you're only required to report on those that are funded through the federal funds.
So in other words, to just add that it may be for continuous quality improvement purposes that programs would work to keep all the participants within the same picture, so to speak, but strictly speaking, the requirement for reporting apply only to those participants that are directly funded by the program.
I would add from our experience in our program, this is Mary, that technically Educare is full day, full year, and we have some part-day classrooms and we have some other program models that program service options that we have in our program so we can serve the needs of the families in our community who are not interested in full day, full year care. And we don't have to, for the Balanced Learning Network, collect data on any of those other service options, but we do because we really want data to inform the program. And if we didn't collect data on all of the children, then we would have a situation where we would be falling short of our philosophy. And so we do collect data on, and we found other funding to collect data on all the children, and we think that it's made a huge impact. And we actually, in the beginning when we didn't, we actually had some service options saying, how come you're not doing that for us? So I think it's been a benefit to collect data on the extra kids. Thanks.
I guess in your program exemplifies this transition from being mere users of data, at times required for compliance purposes, to being the owners benefiting from capturing them.
Okay, great. This question is for Lauren and Carlos. It was mentioned that this compendium of measures is being developed. Will these serve as national performance measures for the home visiting program?
Go for it, Lauren.
The intent is not to create national performance measures for the home visiting program. As Carlos mentioned in his slides, this was done because we wanted the flexibility to be responsive to the potential multiple program models and other requirements. The intent of the measures compendium is to give you a starting point of some measures that are out there and access to some of the information you'll need to provide in your measurement and data collection plan. And that document will also be a living document, and that as we learn about new measures, we'll be adding to that document and updating it.
And that said, if programs would like to adopt performance measures that are already existent and that they may be utilizing, we're in fact encouraging that. We're encouraging the possibility that various agencies utilize common measures so that we can aggregate from program to program and have a better picture of what's happening in a particular benchmark area. So we're not requiring it, but we are encouraging grantees to utilize what's already available and, if possible, utilize the national measures that other programs utilize.
Assuming they meet the requirements specified.
Assuming they meet, exactly.
Yeah.
Well, that opens the door for another question, which was, if all states are using different measures, how will we be able to draw conclusions about the program's effectiveness?
The national evaluation that is being planned of the home visiting program will collect consistent measures across models and across the participating states. And Congress is quite clear in the language around that evaluation that we'll be drawing conclusions about the program's effectiveness in that evaluation.
Okay, the next question is, are there any measurement tools normed for the Native American population? And I actually will take that one and say that we recognize that there may be limited information on norms for tribal communities. So under our TA contract, we plan to do more technical assistance with the tribal grantees on this topic. So stay tuned for more information on that. Okay, the next question is, are there any suggestions on managing data collection across the models? For example, models using different tools to measure the same areas. We want all programs to use the same tools, but we don't want to interfere with the model or overburden staff families with using multiple tools. I think that's a great question, and it's going to be a difficult issue. I think it's too difficult for us to really hammer out on the webinar today, but I would encourage you to contact your personal project officer and raise the question, and then if additional technical assistance is necessary, then they will be the ones to facilitate that connection.
Okay. The next question is, I understand that grantees must move 50% of the constructs in each benchmark domain. Is this a correct interpretation of the SIR?
Yes.
Okay. The next question is, the benchmarks for improvement in school readiness includes constructs for child cognitive skill development, etc. Since infants developing into toddlers will all demonstrate this, how should these benchmarks be developed?
I think this is where the states or the grantees are going to have to look at the population served and the models used and what are the appropriate measures of these constructs. We recognize that measuring school readiness for infants and toddlers is slightly difficult, but we are interested in precursors to school readiness as well. So there are measures out there that will capture some of the domains around cognitive development for infants, and I think that's another one where I would encourage people to come onto the calls where we'll be digging deeper into some of the specific domain areas.
Okay, next question. Some constructs require measurement or change in measurement from point in enrollment to 1 year post-enrollment. If a client discharges before 1 year of service, do we exclude them from the data even though they are part of the families that were enrolled during that year?
We are not asking programs to follow up participants who have dropped out of the program prior to the 1 year of data, with the caveat that I think we'll have to think about it on a case-by-case basis on measures and situations, but in general, we're not asking people to follow them longitudinally if they've dropped out.
I'm sure on the silent, muted phones, everybody's cheering. Okay, so the next question is, if we use the funds to expand existing home visiting programs, is it okay to report on all participants served, or do we have to find ways to separate out those participants that are added to the caseloads with this new funding?
However, I'll take it. You should have a data system that will allow you to separate out those participants funded by the federal funds.
Okay. The next question, if we need to administer a measure to families who speak a language other than English or Spanish, can we just translate it?
Susan, do you want to take that?
Well, just some cautions. In English, if it into another language, to those also the person they have it available in another language.
Susan, can you pick up your handset and answer?
I would be very careful to make sure that you have it translated professionally and then maybe pilot it with another group before you administer it class-wide across the program.
And I'll add to that you have to be careful that the norms then available may or may not be still appropriate for that new population. So I would encourage you to seek technical assistance around those issues.
And some things don't directly translate. So a lot of language assessments wouldn't, because different languages have different sort of structures, language assessments don't usually translate well. An example is carrot's a very basic word in English, and I can't pronounce it in Spanish, but it's a multisyllabic word in Spanish. So different words are different, have different sort of difficulties and different meanings, and language development proceeds differently in different languages. So you wouldn't want to just translate a language assessment.
Yeah, and I think it crosses to not even just language assessments, but I know that there was a translation of the child behavior checklist, and in one of the languages, the word steal culturally was much more offensive than it would be considered in English, and so participants were less willing to endorse that item, even if the construct, the way we think about it, might have been the same.
Okay, and a similar question is, what should we do if we have a diverse community and there isn't a measure that has norms for our population?
I would encourage you to work with technical assistance providers about this particular issue. I mean, some measures have been normed on pretty diverse populations, others have not, and so it would be worth having a conversation to weigh the pros and cons of a particular measure for your population.
Okay, next question. If Congress is requiring a national evaluation, will states be asked to administer additional tools with families they are serving with this grant if they are not the same tools the state chooses to administer?
The plan currently with the national evaluation is that it will be an external evaluator who will be administering the measures. So, though we haven't finalized the plan, and I would encourage people to follow those discussions as they're ongoing, but our hope is to balance burden.
Okay, one of the questions was whether we would be able to provide a transcript of the Q&A, and the answer is yes to that. We will be able to post the answers on the same website where the webinars will be archived, which is the website that has the pink highlight underneath it. Okay, this is a question about specific domain area, and the question is, do you have any suggestions for measuring preconceptual care, given that many programs engage mothers or participant mothers during the prenatal period?
Carlos?
I'll have to think about that because the participants will be mothers, the adult participants will include mothers and expectant mothers. A woman who... Yeah, go ahead.
I was going to say, my memory of the discussions was that this is broader than just pregnant women, that this is about women's health in total. So it would include women who are enrolled currently with infants and older children, assuming that preconception care just means maternal health broadly. But, Carlos, you can correct me if I'm wrong.
Yes, I think that we're conceptualizing preconception care as part of women's health generally.
Okay, the next question is for Mary. Mary, does Clayton have an early Head Start home visiting program? And if so, how do the home visitors use the data?
We do have an early Head Start home visiting program, and like I mentioned before, we have many different program options. And actually, our home visiting early Head Start is the one program option that we have yet to really bring this partnership into, and they're the ones that sometimes say, how come we don't get this? So we're still working on that. We're trying to find funding and design something. But we do this sort of thing with our Head Start home visiting program, and what we do is we collect data twice a year, and then we feed it back to the home visitors. and the home visitors bring the data back to the parents, and they discuss with them, and they do the same sort of conversation where they talk about how the data that we've collected lines up with their own observations, and then they do the same sort of things to plan for kids and plan enrichments for additions to the HIPPY curriculum, which is what they use for home visiting. So we haven't gotten there yet with early Head Start.
Okay, thank you. This question is for Carlos. When will each grantee have to submit their data for year one? And do states have a due date to tell the local home visiting programs what benchmarks they have to collect and submit?
Carlos, are you muted?
Oh, I'm muted, sorry. I'm so sorry.
I wish it back on to see if I was muted.
I was waxing passionately. As I mentioned, in the presentation, we are not yet, we don't have yet available neither the template that we will publicize as soon as they are developed and approved, nor the timing of reporting. Nonetheless, the SIR includes the notion that reporting has to be annual, and the starting point will be when participants are starting to be served by the program, which is, in this instance, after the updated plans are approved. So it won't happen for a while that states will need to report. And could you repeat the second part of the question?
Yes. The second part of the question was, is there a due date for which the state agencies would give to the local program sites about when they have to submit that data to the state?
I'm not sure I understand the question, but the states, it's a state's prerogative to set up a plan for the benchmarks and the submission of data, and the arrangements they enter into with models and the agencies. It is really, if I'm understanding the question correctly, it's really up to the state, and it will depend on what the state plan is. So I think that will be something that we will need to engage in with the states and after the plans are developed. Is that something that, Lauren, you would like to...
That sounds right. No, your answer sounds right.
Okay, the next question has to do with the compendium again. The question is, will the compendium crosswalk benchmarks the data collected by specific home visiting models?
Susan, you want to take it?
Yes. The way the compendium is currently structured is it's organized by constructs and subconstructs, not by models. And that will hopefully make it more applicable across all models. So right now it's not organized that way.
Okay, and then we've gotten several different questions about norms for different standardized measures and specific target populations, and asking whether there's more information about specific target populations. And in the compendium of measures, there is a brief description of each measure, as well as a link to a website that has further information about each of the measures, which includes psychometric properties and the different populations that it's been tested with. So that will be part of that document. Okay, the next question is for Mary. How do the families react to the data that you're collecting and reporting back?
I think that I think there's probably mixed reactions, but I think most families enjoy getting it. I'm not there when they get it, but teachers often comment that, oh, mom will be really excited to see that, or mom was really worried about that, and this confirms her concern, that kind of thing. So, and we've also had the interesting experience where teachers have wanted to refer children. They've suggested that they refer children for an IEP or an ISSP, and the parents have been resistant. And the teachers sometimes, they've had many experiences where the teachers said, oh, maybe this will be the thing that'll, because the teachers have their own observations because they're concerned about a child. And then when the test results come in, they are in line with the teacher's observations. But sometimes seeing something in writing with a number and a percentile is what sort of gives the parents that extra nudge to make them be open to the referral, and so it's been really valuable in that way as well. So I think that it's once in a blue moon I get a parent who wants to, I'm always open to parents contacting me to discuss the test further, and I don't get a lot of parents doing that, but periodically I do, and in that case they're really excited to get this extra information about their children, and they see it's a benefit. So I think that for the most part parents really do enjoy getting it.
Great, thank you. Okay, the next question is, what if the home visiting model tools are not valid and reliable tools? I think this question is getting at whether the model developers' required tools are not valid and reliable. So I'll answer it with that in mind. The requirements in the FAR do require a valid and reliable measure. So I would encourage you to talk to your first RPO about those specific circumstances, but the FAR does have that requirement. Okay, and a similar question related to the national models is, have there been any discussions with the national program officers for the models regarding model-specific things they're willing to do to support the data collection requirements at the state level? So I think basically, are there discussions with the national models about how to incorporate some of the new data collection requirements into their programs? Carlos, do you want to take that one? Or do you want me to?
Sure. I'm not exactly sure. We are going to engage with model developers, but I'm not certain what the items of the immediate agenda will be.
Yeah, I think it's an ongoing relationship that we'll be building with the model developers, and those relationships are just getting started. Okay, great. Well, it's almost 4:30, so this concludes today's webinar. We hope to continue this conversation through upcoming peer learning opportunities, individualized technical assistance. Thank you very much for your time, and please refer to the website we mentioned previously for the archived FAQ and the link to the slides and the audio taped version of the webinars. Thank you.